Cardiac arrest is one of the most critical emergencies encountered in medical practice. When the heart suddenly stops pumping blood, vital organs are deprived of oxygen, making rapid intervention essential. Medical personnel must act swiftly to diagnose and initiate cardiopulmonary resuscitation, or CPR, to prevent irreversible damage and save lives. In this video, we'll explore the causes, diagnosis, and treatment of cardiac arrest, focusing on the step-by-step procedures of CPR. Understanding these protocols can make a life-or-death difference, whether you're a healthcare provider or a bystander. Let's begin by defining cardiac arrest and why immediate action is so crucial. Cardiac arrest occurs when the heart is unable to sustain an effective output, leading to a cessation of circulation. This means that blood no longer flows to the organs, depriving them of oxygen and nutrients. Without prompt intervention, brain damage can begin within minutes, and death can follow soon after. CPR is an emergency procedure designed to manually preserve brain function and restore blood circulation and breathing. It's indicated for anyone who is unresponsive and not breathing normally. CPR is continued until spontaneous circulation returns or the patient is declared dead. The foundation of successful CPR is immediate action, which preserves the body for advanced interventions like defibrillation. Studies have shown that immediate CPR, followed by defibrillation within 3 to 5 minutes of sudden ventricular fibrillation cardiac arrest, dramatically improves survival rates. The sooner CPR is started, the greater the chance of preserving brain function and restoring heart activity. This underscores the importance of recognizing cardiac arrest quickly and acting without delay. Whether in a hospital or outside, the first few minutes are critical. CPR serves as the bridge to advanced life support, keeping the body viable for further treatment. Let's now look at the various causes of cardiac arrest, so you can better understand the risks and triggers. Cardiac arrest can result from a wide range of conditions. Cardiac diseases such as coronary artery disease, valvular lesions, cardiomyopathies, and heart blocks are common causes. Other factors include hypoxia from respiratory obstruction or disease, hypotension due to massive blood loss, and hypoglycemia, especially in diabetic patients or those undergoing surgery. Fainting during anesthesia, drug effects like intravascular injection of adrenaline, and sensitivity to local anesthetics can also trigger arrest. Electrolyte imbalances, such as intravenous calcium administration or high serum potassium in diabetic acidosis or renal failure, are additional risks. Understanding these causes helps in prevention and rapid response. Beyond the primary cardiac causes, cardiac arrest can also be triggered by vagal reflex mechanisms during intubation or surgical stimuli, leading to bradycardia. Terminal stages of diseases like diabetic coma or malignancy may also result in cardiac arrest. It's important to recognize these less common etiologies, as they can occur in various clinical settings. By understanding the broad spectrum of causes, medical personnel can better anticipate and manage cardiac arrest situations. Let's move on to the pathophysiology of cardiac arrest and how CPR works to maintain vital organ function. When cardiac arrest occurs, the body's tissues are deprived of oxygen and blood flow. CPR is used to oxygenate the blood and maintain cardiac output, keeping vital organs alive. The physiology of CPR involves generating a pressure gradient between arterial and venous beds, achieved through chest compressions and rescue breathing. The brain can sustain damage after about 4 minutes without blood flow, and irreversible injury occurs after 7 minutes. If blood flow ceases for 1 to 2 hours, body cells die. CPR is most effective when performed within 7 minutes of blood flow stoppage. Low body temperatures, as seen in near drownings, can prolong brain survival. Effective CPR enables enough oxygen to reach the brain, delaying brainstem death and keeping the heart responsive to defibrillation attempts. Defibrillation is a critical intervention for certain types of cardiac arrest, such as ventricular fibrillation. The combination of immediate CPR and timely defibrillation can significantly improve outcomes. Medical personnel must be trained to recognize when defibrillation is needed and act quickly. Let's now discuss how cardiac arrest is diagnosed, so you know what signs to look for in an emergency. Diagnosing cardiac arrest involves checking for the absence of pulse in major vessels like the carotid or femoral arteries. Auscultation of the heart reveals no heart sounds, and respiration ceases with no breath sounds. The skin may appear pale or cyanotic, and the person is usually unconscious, responding poorly or not at all to stimuli. Pupils may be dilated with a sluggish reaction to light. These signs indicate that immediate CPR is necessary. Recognizing these symptoms quickly is vital for initiating life-saving interventions. Treatment of cardiac arrest centers around immediate initiation of CPR. Anyone present at the time of cardiac arrest should begin CPR without delay. Management depends on whether the arrest occurs inside or outside the hospital and whether there is a single or double rescuer. Outside the hospital, basic life support, BLS, is provided. Inside the hospital, advanced care life support, ACLS, and post-resuscitation life support are added, collectively known as Cardiac Pulmonary Cerebral Resuscitation, CPCR. The goal is to restore circulation and oxygenation as quickly as possible. Basic life support aims to maintain oxygenation in the lungs, brain, and heart through rescue breathing and cardiac compressions. The classic sequence is airway, breathing, circulation, ABC, but recent guidelines emphasize circulation first, followed by airway and breathing, CAB. Each part begins with an assessment phase to determine the patient's response, presence of pulse, and state of respiration. BLS is the foundation of all resuscitation efforts, providing critical support until advanced interventions can be applied. When the victim is unresponsive, the first step is to position the patient supine on a firm, flat surface. The rescuer should be at the victim's side, at a distance equal to the width of the victim's shoulders. Airway management involves the triple maneuver: opening the mouth, head tilt and chin lift, and jaw thrust. In unconscious patients, muscle tone is impaired, causing airway obstruction by the tongue and soft tissues. Moving the lower jaw forward lifts the tongue away, opening the airway. Loose dentures and foreign material should be removed quickly to prevent complications. The head tilt and chin lift technique is essential for opening the airway. Place one hand on the victim's forehead and apply firm backward pressure to tilt the head back. With the fingers of the other hand under the bony part of the chin, lift the chin forward and support the jaw. This maneuver helps relieve airway obstruction caused by the tongue. If there is a foreign material or vomitus in the mouth, remove it quickly. Be cautious with loose dentures, as they can interfere with mouth-to-mouth breathing. The jaw thrust technique is used to further open the airway, especially when neck injury is suspected. Grasp the angle of the victim's lower jaw and lift with both hands, displacing the mandible forward while tilting the head backward. If foreign material is present, remove it promptly. Devices like Guadal's or Safar's airway, laryngeal mask airway, or esophageal gastric tube may be used if available. These tools help maintain airway patency during resuscitation. Airway obstruction by a foreign body requires immediate action. Back blows are delivered to the middle of the patient's back, typically 4 times, to produce a cough and dislodge the object. The Heimlich maneuver involves manual thrusts with the rescuer behind the patient, compressing the chest 6 to 10 times. For unconscious patients, the finger sweep method can be used to remove foreign bodies from the mouth. These techniques are vital for restoring airway patency and preventing further complications. To assess breathing, place your ear near the victim's mouth or nose. Look for chest wall movement and listen for breath sounds. If breathing is absent or abnormal, Expired air resuscitation is required. This can be done through mouth-to-mouth, mouth-to-nose, or mouth-to-airway breathing. These methods provide oxygen to the victim and are essential steps in basic life support. Let's explore the techniques for rescue breathing in detail. Mouth-to-mouth breathing is a quick and effective way to provide oxygen to the victim. Open the airway using the triple maneuver. Close the victim's nostrils with your thumb and index finger. Take a deep breath and form a seal with your lips around the victim's mouth before exhaling. 2 slow breaths, each lasting 1 to 2 seconds, are given to ensure good chest expansion and minimize gastric distension. This technique is fundamental in CPR and can be performed by anyone trained in basic life support. When mouth-to-mouth breathing is not possible, mouth-to-nose breathing is an alternative. Tilt the victim's head back, close the mouth, lift the lower jaw, and form a seal with your lips around the victim's nose before blowing. Allow the victim to exhale naturally. This method is useful when the mouth cannot be opened or a seal cannot be formed. It's important to adapt your technique based on the situation and the victim's condition. Mouth-to-airway breathing is used when airway devices are available. Open the airway with the triple maneuver. Close the victim's nostrils and give 2 slow breaths, each lasting 1 to 2 seconds. This ensures good chest expansion and reduces the risk of gastric distension. Barrier devices like masks and face shields can also be used to protect the rescuer and provide effective ventilation. Let's look at how these devices work. Barrier devices, such as masks and face shields, are used during expired air resuscitation to protect the rescuer. Most masks have a one-way valve to prevent exhaled air from entering the rescuer's mouth. The device should have low resistance for gas flow to avoid fatigue. Position the barrier device over the victim's mouth and nose, ensuring an adequate air seal. Breaths are given in the same sequence and rate as described earlier. These devices improve safety and efficiency during rescue breathing. Mouth-to-mask breathing uses a transparent mask with a one-way valve mouthpiece. Some devices have an oxygen adapter for supplemental oxygen. This method allows the rescuer to use both hands to create a tight seal around the victim's mouth and nose. Proper positioning and sealing are crucial for effective ventilation. Lift the jaw while performing a head tilt and follow the same sequence as mouth-to-mouth breathing. This technique is reliable and preferred in many clinical settings. Checking circulation is a key step in CPR. The carotid artery is the most easily palpable, located between the trachea and large neck muscles. If no pulse is felt, external cardiac compression should be started immediately to establish circulation. This step is vital for maintaining blood flow to the organs and increasing the chances of survival. Let's review the technique for external cardiac compression. External cardiac compression involves applying pressure over the lower half of the sternum at a rate of more than 100 per minute. The victim should be supine on a firm surface. Locate the lower margin of the sternum. Place the heel of one hand on the sternum and the other hand on top. Keep fingers interlocked, elbows locked, and shoulders directly over the hands. Compress the sternum 0.5–1.5 inches for adults. Release pressure after each compression to allow blood flow. Optimal compression generates an adequate carotid pulse and is essential for effective CPR. During CPR, continuous assessment is necessary. Inspect for chest rise, depth of compression, and position of hands. Palpate for return pulse and assess peripheral pulses. Auscultate for breath and heart sounds. In one rescuer CPR, perform 30 compressions followed by 2 ventilations. Then check for carotid pulse. If absent, resume CPR. With 2 rescuers, maintain a compression to ventilation ratio of 15:2. Proper assessment ensures effective resuscitation and guides further interventions. Advanced cardiac life support builds on basic life support by adding adjunctive equipment and techniques. In a hospital setting, ACLS includes ECG monitoring, arrhythmia recognition, defibrillation, IV access, and drug therapy. The primary survey continues the ABCs of BLS, with defibrillation as a key step. ACLS is essential for evaluating and restoring spontaneous circulatory function, especially in complex cardiac arrest cases. The ACLS primary survey continues the ABCs of BLS and emphasizes defibrillation first. The sequence is airway, breathing, circulation, and defibrillation, ABCD. Each step is critical for restoring heart function and oxygenation. Defibrillation is performed as soon as possible in cases of ventricular fibrillation or pulseless ventricular tachycardia. Let's review the secondary survey and the role of drug therapy in ACLS. The secondary survey in ACLS involves endotracheal intubation for airway management, assisted ventilation, circulatory support with IV access, rhythm identification, blood pressure measurement, and appropriate medication. Differential diagnosis is also performed to find and treat the underlying cause of cardiac arrest. This comprehensive approach ensures that all aspects of resuscitation are addressed, improving the chances of recovery. Drug therapy is a secondary management during cardiac arrest, following airway management, ventilation, chest compression, and defibrillation. Common drugs used include adrenaline, atropine, lignocaine, calcium, and sodium bicarbonate. Each drug has specific indications and dosing protocols. Adrenaline is the drug of choice for CPR, enhancing peripheral resistance and increasing coronary pressure. Let's look at the actions and doses of these medications. Adrenaline is the most widely accepted vasopressor drug for CPR since the 1940s. Its alpha-adrenergic properties increase peripheral resistance, raising aortic diastolic pressure and improving coronary blood flow. The empirical dose is 10 micrograms per kilogram of body weight, repeated every 5 minutes. Adrenaline remains the drug of choice for cardiac arrest, providing critical support during resuscitation. Atropine enhances sinus node automaticity and atrioventricular conduction by its vagolytic effect. It is indicated in asystole and when bradycardia coexists with hypotension. The adult dose is 0.5 milligrams IV every 3 to 5 minutes, up to a total of 0.4 milligrams per kg. For children, the dose is 0.2 milligrams per kg, with a minimum of 0.1 milligrams per kg. Atropine is a valuable drug in specific cardiac arrest scenarios. Lignocaine, also known as xylocaine, is indicated for ventricular tachycardia and ventricular premature contractions. The dose is 1 milligram per kg body weight, followed by 0.5 milligrams per kg, and then an infusion, with a maximum of 3 milligrams per kg. This drug helps stabilize abnormal heart rhythms during cardiac arrest and is an important part of advanced cardiac life support. Calcium is indicated in hypocalcemia, hypercalcemia, and calcium channel blocker overdose, with a dose of 10 milligrams per kg body weight. Sodium bicarbonate is used for metabolic acidosis, prolonged arrest, and hyperkalemia. The initial dose is 1 milligram per kg, with half the dose repeated every 10 minutes. If blood gases are known, the dose can be calculated as 0.3 times base deficit times weight in kg. These drugs address specific metabolic and electrolyte issues during resuscitation. Other drugs used in CPR include dopamine, dobutamine, calcium chloride, and amrinone, vasopressors like norepinephrine and phenylephrine, as well as vasodilators like nitroglycerin and sodium nitroprusside, may be used depending on the clinical scenario. Each drug has specific dosing and indications, contributing to the comprehensive management of cardiac arrest. Defibrillation is a key intervention in cardiac arrest, especially for ventricular fibrillation and pulseless ventricular tachycardia. External defibrillation involves delivering an electric shock to the heart to restore normal rhythm. Proper technique and timing are essential for success. Medical personnel must be trained to recognize arrhythmias and use defibrillators effectively. Let's review the diagrammatic representation of external defibrillation. CPR can lead to complications such as rib fractures, gastric laceration or rupture, splenic rupture, and pneumothorax. These injuries are more common with vigorous compressions, but are outweighed by the life-saving benefits of CPR. Medical personnel must be aware of these risks and monitor for complications during and after resuscitation. Let's discuss ischemic injuries and outcomes of resuscitation. Ischemic injury following cardiac arrest can affect the kidneys, brain, liver, and other organs. The extent of injury depends on the duration of arrest and the effectiveness of resuscitation. Prompt CPR and advanced interventions reduce the risk of irreversible damage. Monitoring for ischemic injury is crucial during the post-resuscitation phase, as it guides further treatment and recovery. The outcome of resuscitation depends on many factors, including the patient's age, cause of arrest, whether the event was witnessed, the rhythm, and the ischemia time. Neurological recovery is about 50% if arrest time is less than 6 minutes and CPR time is less than 15 minutes. If arrest time exceeds 6 minutes and CPR time exceeds 15 minutes, chances of survival are almost nil. Early intervention is key to improving outcomes. Flowcharts summarize the protocols for managing adult cardiac arrest. The steps include immediate assessment, initiation of CPR, airway management, rescue breathing, circulation check, and advanced interventions like defibrillation and drug therapy. Following these protocols ensures a systematic approach to resuscitation and improves the chances of survival. Management of pediatric cardiac arrest follows similar principles but with adjustments for age and size. Protocols include assessment, airway management, rescue breathing, circulation check, and advanced interventions. Dosing of drugs and techniques may differ, so it's important to follow pediatric guidelines. Flowcharts help visualize the steps and ensure proper care for children in cardiac arrest. To summarize, CPR involves a sequence of steps: assess responsiveness, open the airway, check breathing, provide rescue breaths, check circulation, and perform chest compressions. Advanced interventions include defibrillation and drug therapy. Following these steps systematically increases the chances of survival and neurological recovery. Training and practice are essential for effective CPR. Key points to remember in cardiac arrest management include the importance of immediate CPR, proper airway and breathing techniques, effective chest compressions, timely defibrillation, and appropriate drug therapy. Monitoring for complications and ischemic injury is also crucial. Early intervention and adherence to protocols are the foundation of successful resuscitation. After successful resuscitation, post-cardiac arrest care is essential. This includes monitoring for complications, managing ischemic injuries, and supporting organ function. Neurological recovery and rehabilitation are important goals. Continued assessment and advanced interventions may be needed to ensure optimal outcomes. Let's review the importance of ongoing care after cardiac arrest. Training in CPR and cardiac arrest management is vital for healthcare providers and the public. Regular practice, simulation, and adherence to updated guidelines ensure readiness in emergencies. Preparedness can make the difference between life and death, so everyone should learn basic life support techniques. Hospitals and clinics should maintain equipment and protocols for rapid response. CPR is not limited to hospitals. It can be performed in community settings by trained bystanders. Early intervention before arrival of emergency services greatly improves outcomes. Public access to defibrillators and widespread CPR training are important strategies for saving lives. Community preparedness is a key component of cardiac arrest management. Advances in cardiac arrest management include improved protocols, new devices, and better training methods. Research continues to refine techniques and drugs, aiming for higher survival rates and better neurological outcomes. Staying updated with the latest guidelines and innovations is essential for all medical personnel. Let's look forward to future improvements in resuscitation science. Cardiac arrest is a life-threatening emergency requiring immediate action. Understanding the causes, diagnosis, and treatment protocols, including CPR and advanced interventions, is essential for saving lives. Early intervention, proper technique, and ongoing care are the keys to successful resuscitation. Training and preparedness empower both medical personnel and the public to respond effectively. Stay informed, practice regularly, and be ready to act in emergencies.